Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to Data and Perspectives. As we have clinical investigators, our faculty today are going to be exploring the application of recent data sets in current oncology care. We're really thrilled to be back here at the Florida Cancer Specialists annual retreat. We've been coming here for 21 years, and I'm going to turn it over to Lucio Gordon for some comments.
Thank you, Neil. Good morning, everybody. Thank you, panelists, for coming here today. Audience that's here and the virtual audience as well. So, Neil, thank you. 21 years together, a phenomenal output of data, discussion. Your panelists, we are so grateful. We continue to do this twice yearly, maybe more. So we're super excited. I hope everybody participates today. Neil, we are super grateful to you and to your panelists. Thank you so much.
Thanks, Lucio. So this morning we're going to start out talking about breast cancer. We will be discussing the use of agents out that are not approved and regimens not approved. So check out the prescribing information for more information. And just a couple words before we get started. We're going to actually infiltrate another theme in here, which is actually a Shark Tank type phenomena. We're going to ask you for your opinion on a couple of new ideas we have. This is our vision now about how we distribute our content, like the content that's coming from this meeting. This is just the beginning when we create the content. Now we're putting it out through podcasting, streaming platforms, email, et cetera, et cetera. Well, one of the things I'd like your opinion on, and maybe you can give us some feedback, let us know whether you think this is going to be a hit or not, is an idea we have, and you should have at your seat, for what we call the 2025 version of the CD. You know, people always loved our CDs. Well, this is similar. As you can see, it's a card that has 12 QR codes, each linking to a video. We have one experimental program for docs, and all these programs that we did are all available on this one card. Just click and play, take it to your car or when you're working out. And also, really excited about the idea of doing them for patients. This is a program we did on myeloma. Again, the idea, you hand it to the patient in the clinic. This actually has a bunch of patients on it. This is about myeloma. And we think we maybe could do some of these on clinical trials. And again, here are some of the things that come off this card. So if you have any thoughts about it, you think it's going to be a hit, or maybe it's going to be, we'll forget it after today, just let us know. Two other ideas, and again, Lucy sort of alluded to it, that we're thinking about bringing into a lot of our work, including the program next year, is one, information on artificial intelligence for the clinician, trying to develop tutorials for particularly people who haven't had much experience with AI, and the other on the science of wellness. If you have any thoughts about that, you think we'd like to see more on that, just let us know. All right, well, let's get into what we're going to cover this morning. And as we always do for this meeting, we did a survey of you all, the attendees. We asked if you have any questions or any cases, and we took those and we stuck it into the old form of artificial intelligence, which is I read every single one of them and tried to pick out the ones I thought were most interesting. And we'll talk about these today. Here's where we're heading. We'll be starting out with a big module on breast cancer. So much going on in breast, even more now with the ESMO meeting coming up. Then we'll talk about prostate cancer, some new developments there. Capivasertib in prostate cancer is going to be presented at ESMO. Should be pretty interesting to see the urologist try to tackle capivasertib. We actually did a program at AONA of that. And we'll talk about colorectal cancer, particularly all the exciting things going on with MSI-high disease. And we'll finish out with diffuse large B-cell lymphoma, follicular lymphoma, particularly the evolution of bispecifics, CAR T therapy, and many other therapies. So first we're going to start out here with breast cancer. To introduce our faculty, starting from the far end here, Dr. Matt Goetz from the Mayo Clinic in Rochester, Dr. Rita Nanda from the University of Chicago, Dr. Harold Burstein from the Dana-Farber Cancer Institute, and Dr. Heather McArthur from the UT Southwestern Medical Center in Dallas. Our format is, as we always do, is we'll do brief presentations and then really we'll dig into practical clinical questions. I was telling the faculty, I always take the boards, just to keep up on what they're doing, and I took it again last night, the every 3-month thing. It's I'll bring those up, some of the things that I saw there. But Matt, let's start out talking about hormone receptor positive disease. A lot going on, particularly in metastatic disease, but also in the local therapy. So let's get started.
Neil, thanks very much. So I have an outline here that describes what we're going to talk about. And I'm going to go through the first part relatively quickly because this is review for all of us. We've seen some of these data over the last several years, and that includes information about the recurrence score and decision-making, extended follow-up of the CDK4/6 inhibitor studies in the first-line setting. Then I want to really talk a little bit more about a very important trial, which is the SERENA-6 trial. It's getting a lot of press, and how that might potentially apply to, and we might integrate that into our practice. So first of all, this is, of course, a seminal study that you're all familiar, which is the Taylor RX study, also called the PAC-1 study, in which patients where there was equipoise with regard to the role of chemotherapy, that is, patients who had ER-positive, node-negative breast cancer, were either given endocrine therapy alone if they had a low recurrence score of 0 to 11, 0 to 10. Those that had 11 to 25, they were randomized to either endocrine therapy alone or endocrine therapy along with chemotherapy followed by endocrine therapy. And then finally, as you know, there was this other group, RMD, where patients had a high recurrence score who were given chemotherapy followed by endocrine therapy. And as you know, this was a really important study for our practice. We continue to utilize this day in and day out, and that's essentially that in these patients with a recurrence score 11 to 25, there was no benefit for the addition of chemotherapy to standard endocrine therapy. But one of the things that we continue to get more information, and by the way, this is really, again, one of the very important aspects of our cooperative group clinical trials, and that is we're able to get information that's not just in short-term follow-up, but this long-term follow-up data, really critical for a cooperative group study like this. And in what we're seeing here, as you can see, is that this is an analysis from Joe Sperano from this back in 2022. The benefit continues. We continue to see that there's no benefit of chemotherapy long-term, both in IDFS, distant relapse-free interval, and overall survival. But one of the things, of course, that has been quite intriguing to all of us is this effect of age or menopausal status, recurrence score, and clinical risk. And what was observed, of course, was that in the premenopausal patients, there seemed to be a benefit of chemotherapy. And you can see there on the right-hand side that recurrence score is 16 to 20. There was a benefit of about 2%, 21 to 25, an even larger benefit. And so this really prompted a lot of questions, of course, and that was, well, why is this? Is it somehow that these patients are different? Is it because they didn't get proper endocrine therapy, which is what most of us think? And so as time has gone on, the ECOG team has looked at this a bit further. They've added information that I think we're all using in our practice, which is, of course, the fact that clinical risk, so tumor size grade, is still important, and this is actually reflected there on the left. You can see that in patients that have evidence for higher clinical risk, that there is a larger benefit. And then on the right-hand side, and I apologize, you can look at this more closely in your syllabus, you can see with long-term follow-up, we're again seeing this evidence that it's really the patients that have higher clinical risk and higher recurrence score where we could begin to see these larger benefits. Now, what about the RX Ponder? Well, this trial, as you know, that was run by SWOG, where patients really had higher clinical risk, because these are patients with nodal positivity. They were randomized, really the same design, chemoendocrine therapy versus endocrine therapy alone. And very briefly, as you know, in this study, in postmenopausal patients, again, similarly, there was equipoise with regard to chemotherapy. We see no benefit. But again, what was seen in patients that were premenopausal was that there was some benefit. And if you look at both of these studies, what you see is that it's clear that patients who were premenopausal were not getting proper endocrine therapy, that is, ovarian function suppression plus an AI. And so what we think, of course, is the fact that in these patients who have a higher risk ER-positive breast cancer, there may be no benefit of chemotherapy if these patients are getting proper endocrine therapy. So my summary here is just is summarizing this, and the fact that we have this very important study that's ongoing, which is the NRG 009. Again, I reiterate the importance of our cooperative group clinical trial system that can answer questions that are important to you as clinicians, that ultimately help us manage our patients. And of course, NRG 009 is simply just saying, listen, in the setting of proper endocrine therapy, is there any benefit of chemotherapy in patients with this recurrence score, 11 to 25? So I'm moving on to the adjuvant CDK4/6 inhibitor studies. These are the studies that you're aware of: Penelope-B, Pallas, Monarchy, and Natalie. And of course, we know that it was the Monarchy and the Natalie studies that showed a benefit of chemotherapy in terms of IDFS. This is the Monarchy study. As you recall, this was a very high-risk group of patients, 4 or more positive lymph nodes, or 1 to 3, with very high-risk features. And as time has gone on, this is the last iteration of data that was published in JCO about a year ago. Median follow-up of 44 months. You continue to see this benefit in terms of the addition of abemaciclib to endocrine therapy. And one of the things that we're excited about, before I get to that, here is some data from the interim overall survival analysis. At this last cut point that was published, there was no statistically significant difference in overall survival. But one of the things that was observed was that if you look at, with each time point that we look out further, so OS1, OS2, OS3, you have a greater number of patients in green that are alive with metastatic disease in the endocrine therapy only arm. And generally, of course, what we know is that if you follow patients long enough, we think that that's going to translate into an overall survival advantage. And of course, there was this press release, as will be presented at ESMO, where the manufacturer announced results that the addition of 2 years of abemaciclib plus endocrine therapy demonstrated, and I'm reading here, statistically significant in an improvement in overall survival. So we're looking forward to seeing those data at ESMO. Similarly, with the phase 3 Natalie study, you're aware of this. What are the differences, by the way, with the Monarchy? The key differences: first of all, the drug, the CDK4/6 inhibitor, was given for 3 years. Second was that there was this group of patients that were allowed that were sort of higher risk node negative, so you can see that there, N0 with grade 2 or genomically high risk features. They also allowed patients with N1 that maybe were not considered genomically high risk. And what you see is that similarly, the Natalie study with the long-term follow-up has shown benefit with IDFS, DDFS, and overall, but no difference in overall survival as of yet. Again, there will be updated data presented from this study at ESMO, and so we're really looking forward to seeing those data as well. So I'm going to switch now to talking about the evolving hormonal treatment landscape of hormone receptor positive advanced breast cancer. This is a slide that I developed years ago, I think when we were still working on Palbo, and that was the first agent. But you can see the new drugs that have come through. Alpelisib, elacestrant, capivasertib, more recently inavolisib. So this is just extremely exciting. Well, what about the first-line trials in the metastatic setting with CDK4/6 inhibitors? Again, just briefly, what we know is that it was the ribociclib studies, Mona Lisa 2 and Mona Lisa 7, that demonstrated a consistent improvement in overall survival. Monarch 3, we just recently updated these data and published these data. It was not statistically significant, but given the N size in this study, it was a 2-to-1 design. We think that the difference is probably quite similar. You can see the absolute benefit there of about 14 or 15 months. So, of course, one of the limitations that we have is there's no head-to-head trials here, and of course, that's we will never have that. We are not going to talk today about real-world data, but this is something, of course, that people are beginning to look at as well. I'm going to end my brief talk today talking about ESR1 mutations, and it's only I show this here because it's really only about a decade ago that we really began to see data about the role of ESR1 mutations. And we've now just seen multiple different therapeutic approaches emerge. Obviously, we had the phase 3 Emerald study that you see here that led to the FDA approval. We have the camizestrant data, and I'm showing you this data here because I'm going to show you data in just a moment from the SERENA 6. But this is the SERENA 2 trial, which is a randomized phase 2 study. And on the left-hand side, you see all patients. On the right-hand side, you see those with prior CDK4/6 inhibitors. And what I want your take-home point with all these is that the benefit of these drugs in this resistant population is quite limited, a difference of only a couple of months. And so what the Serena, here's a quote that I quite love. This actually came from my mentor, James Ingle, and this is an old quote: "Prevention is so much better than healing because it saves the labor of being sick." And now we're not going to talk about prevention, but maybe secondary prevention. And this is the camizestrant study. This was the study that was designed to bring camizestrant into a earlier stage, or into a minimal residual disease setting. This was a phase 3 double-blind randomized ctDNA guided trial. Here's the design. Patients who were on first-line therapy with a CDK4/6 inhibitor with an AI were randomized at the sign that they had evidence for an ESR1 ctDNA that was by a blood specimen that was rising, and patients were randomized to either camizestrant along with continuing the CDK4/6 inhibitor versus continuing the AI. I'm not going to spend a lot of time here on this, but there was over 3,000 patients screened in order to randomize about 300 and some patients. And you can see here the patient characteristics. The bottom line in this study was that the patients who were randomized to the camizestrant plus CDK4/6 inhibitor had an improvement in progression-free survival compared to continuing. What I thought was quite interesting here was how well the AI group did, a median PFS of 9 months. And we go on and talk about what are some of the concerns about this study. Obviously, there was just a very novel design, very interesting. And I think the main concern that a lot of us have raised is that this study design was testing both a new treatment strategy and a novel drug, and both in the experimental arm. And so we're not really able to understand whether this experimental approach is actually better than the old approach. And that's because there's no crossover to determine which strategy is best. I'm going to finish because I'm over here, but I still think that the question that came to my mind is there evidence that treating patients early, getting back to that quote, could it potentially be better? And this was the global quality of life. And you can see there up in the top-hand screen that it appeared that actually switching led to, if you will, improvement in time until deterioration. But I think there was a little bit of a disconnect there because you can see in terms of progression-free survival that patients' global deterioration in health occurred before they actually progressed. And so it's not quite clear about that. So I'm going to summarize and just end here. These ESR1 mutations, they're common. They occur up to 50% of patients who progress on CDK4/6 inhibitors. We're seeing evidence for the oral SERDs. And I think the question about SERENA-6 really is, given some of the issues with the design, is this really something that is the best approach for our patients? I really want to see more data on quality of life as we go along, and I'll end. Thank you.
Thanks, Matt. And let's get into some of the questions that sort of come out of this, and also the questions we got from the attendees here. Matt mentioned the ESMO meeting actually next week, and actually a week from tomorrow we'll see the BEMA survival data. It's going to be interesting. 2 years is interesting compared to 3. Well, let's get into some of the questions we got about the topics Matt just covered. So Hal, Oncotype or Mammaprint, how do you choose which one? Do you ever use both?
Oncotype, no. We have an institutional practice and algorithm, and if the tumor is greater than 1 centimeter and affects up to 3 positive nodes, we have a reflex where the Oncotype is automatically sent. I like it for 2 reasons. The first is that there's just so much more data for the use of the Oncotype DX in terms of making clinical decisions, as Matt just alluded to. And we actually have a good sense that it's not like a yes or a no dichotomous result. There's a gradation. You can use that information clinically to begin to figure out sort of how much risk there is and whether you want to dial in a little more or a little less therapy. So we have tremendous familiarity with it and huge validity with it. So that's the only product we routinely use.
So Rita, interesting question. We've heard this ever since the Oncotype came out. Can you give chemo but de-escalate? Maybe not use an anthracycline based on Oncotype. Any thoughts?
Yeah, it's interesting. For a lot of my hormone receptor positive patients, I've historically used TC for these patients. But one of my colleagues, Nan Chen, did a study looking back at some of the data from some of these trials. And, interestingly, what we found was that for patients who have a higher oncotype score and a tumor's over 2 centimeters, they really do seem to benefit from the addition of an anthracycline to taxane. Now, I will say that data is very biased. It was not randomized. It was retrospective analysis of a prospectively done trial, and obviously physicians chose what they felt was in their patient's best interest, TC versus anthracycline-based therapy. But I will say, in the absence of having randomized data, for my patients who have large tumors and oncotype scores over 31, I do consider adding an anthracycline now, when historically I did not.
So, Heather, another question that's been out there for a while. We see so many people with ER-positive, HER2-negative disease, big tumors. They get chemo. They don't seem to benefit. It's kind of frustrating. What about using oncotype in the neoadjuvant setting or any genomic assay?
We've increasingly been using, and our preference at our location is to use oncotype for node-negative and node-positive disease where indicated. We're increasingly testing on the diagnostic biopsy, in part because we have several clinical trials in that space that depend on the oncotype information. But also there are selected patients in whom it's helpful to understand that they don't need chemotherapy, and you want to potentially downsize the tumor with a neoadjuvant endocrine therapy approach.
So, Matt, here's an interesting case that was sent in from one of the attendees. Infiltrating lobular cancer that's more than 5 centimeters with 3 positive lymph nodes on MRI, gets a mastectomy and node dissection. Or would you do a mastectomy, go to a surgery, do neoadjuvant chemo, or check oncotype or mammoprint or another genomic assay? How do you handle big infiltrating lobulars, Matt?
Yeah, this is a great question. And, many people who know me know that I'm an endocrine guy. But I think what we would say here in this situation is that if you have a scenario where you have a large tumor, multiple positive lymph nodes, that even though we know that giving neoadjuvant chemotherapy doesn't lead to high path CR rates, that doesn't answer the most important question is do these patients benefit from chemotherapy? We don't have data to suggest that they do not. And of course, we do actually have data that suggests that if you give neoadjuvant chemotherapy to some of these ER-positive breast cancer patients where you're concerned about whether they would benefit, you actually see fairly high rates of nodal PCR. And that's associated with survival. So I think in this scenario, something like this, I would still at least consider chemotherapy. Obviously, I would look at other things. Certainly, age is an appropriate factor here. But I think it's not a cut and dry case that, infiltrating lobular cancer doesn't benefit from chemotherapy per se.
So, Heather, we're talking about neoadjuvant therapy. What about CDK inhibitors in the neoadjuvant setting, particularly as one person brings up in a patient who needs tumor shrinkage for breast conservation, didn't respond to chemo?
Well, I wouldn't normally do that in the neoadjuvant setting because the majority of patients treated on the Natalie and Monarch E studies had chemotherapy. So we don't yet have data that CDK with hormone therapy is a replacement strategy for chemotherapy. So that wouldn't be a typical approach for me.
So how do you approach a patient who has hormone receptor positive disease, metastatic disease, HER2 negative, and visceral crisis? Has a visceral mets, is very symptomatic. Would chemo fit in, or would you just go with hormonal therapy? Would you do both?
Yeah, so the key question here is visceral crisis, and what does that really look like? So there are patients who have metastatic disease to visceral organs in the liver and the lung, and we know from high-level data that those patients can do very appropriately with initial endocrine therapy and CDK4/6 inhibitor therapy. Every once in a while, you see someone who truly has pending hepatic failure, respiratory failure, and perhaps we just sort of throw more at them, especially if they have recurred, on endocrine treatment and you're less sanguine that there will actually be benefit from endocrine therapy. But the first drug out the box should usually be endocrine treatments and targeted therapy unless someone is truly, hospitalized, very sick with metastatic disease. And fortunately, those true visceral crises are just not that common.
So, Matt, you were talking about the data with adjuvant CDK. We're going to see more next week at ESMO. I'm curious right now, and maybe after you see the survival data, how you're going to be thinking through choice of CDK with a node-positive patient. Do you follow the trial thing of ribo for 3 years, abema for 2? Because that certainly seems like a big difference. And also, what about abema in a node-negative patient?
Yeah, I think, first of all, we're going to see data at ESMO, excuse me, not only for abema, but also for ribo. And for a node-positive patient, I typically use abemaciclib, especially if they fit the criteria for Monarch E. Why? Because there's long-term follow-up, and they can take the drug for 2 years. They don't have to take it for 3 years. Now, as time goes on, if we see evidence that there is differential benefit for taking the drug longer, meaning we see differences, obviously we'll never have head-to-head data. That'll be something to consider. But for right now, I generally follow the criteria set up in the FDA label.
So Hal?
Just as we look forward to these data, something really important to remember about Natalie and Monarch E. These are completely different patients than your average postmenopausal patient with node-positive or node-negative disease. In the clinical trials, they went out of their way to select a high-risk group of patients by virtue of grade or oncotype or tumor stage. And if you compare the data for like RxPonder versus the risks that we've seen in those other trials, the patients on those trials have a 3-fold greater risk of metastatic disease than your average ordinary patient who's got like 1 positive lymph node and a recurrence score of 22. So bear that in mind as you begin to look at these data. This is a highly selected group of individuals. It's not clear that most patients with node-negative or node-positive disease need these treatments.
Actually, I shouldn't be saying this, but the one node-positive case with oncotype was one of the boards that I took last night.
Did you get it right?
Got that one right. So, Heather, it kind of sounds like Matt is reflecting the opinion of the discussant of the SERENA-6 trial, Dr. DeMichelle at ASCO, who was like, we need to wait for more data. But the way we do things is that we like to survey people and see if there's any granularity to that answer, because that's kind of the message a lot of people have gotten. We need to hold off. But it's pretty interesting when we did a survey. Actually, this is part of some data we are going to present at San Antonio. So we did a survey of 20, and we're going to show more of this later, 20 investigators. We said, is SERENA-6 ready for prime time? And you can see most of them agree with Matt, 13. But 7 say yes. And in a parallel survey we did of 50 general medical oncologists, even more people said yes. 2/3 of oncologists in practice say yes. I see Hal's shaking his head. He's ready to jump off the chair. I'm pretty sure I know which group he was in. But just kind of what are your thoughts, Heather? And when you have, these are pretty prominent people saying yes, incidentally. When you have people who are saying, there's situations, and maybe not every single patient, but some situations where I think I'd like to do this, there's a PFS advantage. Any thoughts? Are you pro or con, Heather?
Well, I'm not totally surprised by these results because I do think we see this in clinic, patients coming in with Signatera results in various clinical scenarios. So I think patients are asking for that, and a lot of our colleagues are facilitating that, so I'm not totally surprised by that. My belief is I'd be in the no camp with the clinical investigators that it's not ready for prime time in the absence of a survival advantage. And there's some downsides to this approach, too, in my mind, in that you're using 2 drugs up front in the first line, which will limit access to clinical trials potentially down the road. So you would no longer, if you used up both drugs up front, qualify for many of the very exciting phase 3 second-line studies that are ongoing.
So we're going to pick up on this after Rita presents some more data, but just want to ask you before you get started, Rita, what your thoughts are about this. And the other question is, even for people who feel like, I'd rather see survival data, do you think this theoretically should be presented to a patient? You have a medical oncologist as a patient who can completely understand the data. Would you let them know about the data, and if they wanted to do it and you could do it, would you do it?
I have to say I'm also in the no camp, along with my colleagues here. I think the concerns are about the trial design, the lack of crossover, as Matt had mentioned, and, blowing through a lot of therapies that might help keep the disease at bay for some time. So I think I'm not ready to adopt this, and so I'm not quite ready to start presenting it to patients.
So we'll continue this, and this discussion is going to continue for a long time. There was a prior trial looking at fulvestrant, similar strategy that was positive as well. But anyhow, that's the way oncology is now and forever. Rita, let's talk about really a huge topic nowadays, ER-positive metastatic disease, particularly second-line therapy.
Yeah. So I'm going to blow through a lot of stuff very quickly. So, and some of this Matt has already touched on, but I'm going to talk about what do we do after patients progress on their CDK4/6 inhibitor-based therapy. And as we all know, a lot of our therapies are molecularly based for patients who are going to go on to additional endocrine-based therapies. And so thinking about targeting the PI3 kinase and AKT pathways, the SOLAR-1 trial is quite old now. I think you're all well aware of it, a randomized phase 3 trial, which led to the approval of alpelisib plus fulvestrant for patients who have PIK3CA mutations, which occur in about 35 to 40% of patients with advanced hormone receptor positive disease. This trial did not allow patients with hemoglobin A1Cs greater than 6.4, so a pretty select population here. I don't know about your practices, but I have a fair number of patients who've got prediabetes or well-controlled diabetes, so that does limit the ability to use this therapy. This patient population, obviously, as you can see here, there was a significant more than 5-month improvement in median PFS for patients who got alpelisib in addition to fulvestrant, but really high rates of grade 3 and 4 hyperglycemia. About a third of patients developed hyperglycemia and then rash also. So this can be a really challenging regimen to give to patients, and that has been the theme for a lot of therapies that target this pathway. Next, we got Capitello 291, presented not all that long ago, a randomized phase 3 trial looking at, again, patients who have second-line therapy. Unlike SOLAR-1, which was done prior to the CDK4/6 approval era, 70% of patients who participated in Capitello had prior CDK4/6 inhibitor-based therapy. So as you can see here in this overall population of patients, this included both patients who had AKT pathway alterations as well as those who did not, that there was a significant 3.5-month improvement in median progression-free survival, less than we saw with SOLAR-1, but these were also patients who'd previously been exposed for the most part to CDK4/6 inhibitor-based therapy. So this agent, CAPI, is more tolerable than alpelisib, at least in my clinical experience, and that was certainly seen in the context of the trial as well. Not as much grade 3 hyperglycemia, not as much rash and diarrhea, although more diarrhea than was seen with alpelisib. So here you can see the progression-free survival in the AKT pathway-altered population. And while there was a benefit seen in the overall population, this was largely driven by those who had alterations in the AKT pathway. So unlike alpelisib, which is approved for patients who have PIK3CA mutations, CAPI is approved for AKT, P10, as well as PIK3CA alteration. So a little bit of a broader patient population that this encompasses. And I think many of us have been using this because of the toxicity profile that we've seen in the clinic. So more diarrhea than we see with alpelisib, but less hyperglycemia, less rash. And most of the hyperglycemia here is grade 1 to 2. We are going to see at ESMO. I wish I were going to ESMO. I decided to cancel last minute, but there are going to be a ton of great abstracts coming out of ESMO this year, and the Victoria-1 trial is going to be presented there. We only have press release information to share, but gedatolisib is a pan PI3 kinase and mTORC1/2 inhibitor, and it has been studied in combination with fulvestrant, and then fulvestrant and palbociclib. And what we know from the press release is that this is a positive trial, that there was a significant improvement seen in median progression-free survival for the triplet in combination with palbo and fulvestrant, as well as the doublet with fulvestrant alone, and apparently benefits were seen in the PI3 kinase wild-type population as well. So really interesting to think about another option for these patients because CAPI and alpelisib are not available for these patients. So what about ESR1 mutations? Matt touched on this briefly in his talk, so I'll go pretty quickly through this here. As we all know, ESR1 mutations are acquired. They're generally not present at de novo, very low rates there. The Emerald trial was a randomized phase 3 trial which led to the approval of elacestrant for patients with ESR1 mutated hormone receptor positive disease. Here, patients were randomized to elacestrant versus standard of care endocrine therapy. The majority of patients here were receiving elacestrant, so 70% elacestrant versus other endocrine-based therapies. And for those who had ESR1 mutations, you can see that there was a significant improvement in median progression-free survival favoring elacestrant versus standard of care endocrine therapy. And the longer duration patients were on their CDK4/6 inhibitor-based therapy, the more benefit they derived from elacestrant versus standard of care therapy. So you can see kind of that cut point of 12 months on their prior CDK4/6 inhibitor-based therapies where we really see a more dramatic improvement in PFS favoring elacestrant. All of the patients obviously had prior CDK4/6 inhibitor-based therapy. In looking at those patients who had double mutations, so ESR1 and PIK3CA alterations, again, we saw a benefit to elacestrant over standard of care therapy in these patients. And then, again, this is just highlighting those patients who were on their prior CDK4/6 inhibitor-based therapy for greater than 12 months. You can see a more dramatic benefit, a more clinically significant, clinically relevant improvement in PFS for these patients. So I think many of us, when we're reaching to what are we going to give patients in that second-line setting, if they've got an ESR1 mutation, giving single-agent elacestrant is certainly an option for these patients and associated with a reasonable improvement in median PFS. Quickly moving on to the EMBER-3 trial. This was relatively recently presented and published, a randomized phase 3 trial which looked at the oral SERD imlunestrant alone versus standard of care endocrine therapy. The majority, about 90% of patients here got fulvestrant, the remaining 10% exemestane, and then also a combination arm of imlunestrant versus abemaciclib. And so here, about a third of patients who participated in this trial had ESR1 mutations, 40% PI3 kinase pathway alterations, and about 60% had prior CDK4/6 inhibitors. So not all patients had previously had CDK4/6 inhibitors. And what you can see here is a modest but statistically significant improvement in median PFS favoring imlunestrant over the standard of care endocrine therapy, and this led to a very recent FDA approval for imlunestrant monotherapy. In looking at the combination arm, imlunestrant plus abemaciclib versus imlunestrant alone, you can see an improvement in median PFS favoring the combination arm, not surprisingly. And when we look at patients who'd had prior CDK4/6 inhibitors, you can see, again, a benefit favoring that combination arm. So really interesting to think about this. The FDA approval did not encompass this combination, but obviously both of these agents are available for use, and so it'll be interesting to think about how we might want to incorporate that into our practices. Looking at the combination of imlunestrant and abema in patients with ESR1 mutations and those without, you can see, again, still a benefit to that combination regardless of ESR1 mutations, which we've seen with our other trials when we look at adding a CDK4/6 inhibitor even to aromatase inhibitors. The ESR1 mutation is not relevant in that case. And then looking at those patients who have got PIK3CA pathway alterations, you can see that's about 35-40% of patients. Again, the combination is more favorable here over imlunestrant alone. So again, just to reiterate, imlunestrant monotherapy is now FDA approved for patients who've got ESR1 mutated hormone receptor positive advanced stage disease, and now is available for use just like elacestrant is. I'm briefly going to mention the VERITAC-2 trial, which looked at randomizing patients to the PROTAC, vepdegestrant versus fulvestrant in patients with hormone receptor positive metastatic disease. This trial also included all comers, and the benefit primarily to vepdeg over standard of care fulvestrant was seen in those patients with ESR1 mutations. And again, a modest improvement in median PFS here. Pretty comparable to what's been seen with imlunestrant monotherapy, pretty comparable to what's been seen in the all-comer population in the EMERALD trial. I'm going to very quickly, in the last couple of minutes here, I'm going to go over, I apologize, review high level, the ADCs. I think you're all well aware of this data, but the Destiny Bresto trial really revolutionized the way we use some ADCs for patients with advanced hormone receptor positive disease. We saw a significant improvement in median PFS and overall survival for patients with hormone receptor positive HER2 low metastatic breast cancer. Patients had received 1 to 2 prior lines of chemotherapy in this setting, and we saw a significant benefit to TDXD over chemotherapy of physician's choice. Fast forward to Destiny Breast 06 here. Again, we saw a significant improvement in median progression-free survival in hormone receptor positive patients, not only with HER2 low, but also HER2 ultra low disease. And so 85% of patients with hormone receptor positive disease fall into this category. And again, a significant improvement in median PFS. We're still waiting for overall survival data to mature. However, the drug is available. I think it's going to be potentially hard to show an overall survival advantage down the road. Common side effects, nausea, fatigue are the big ones that we face in the clinic. And then obviously we always have to think about interstitial lung disease. When we look at PFS2 in the overall intent to treat population, we're seeing an advantage here. I think really thinking about, are there certain patients that we want to consider giving TDXD2 in that frontline metastatic setting after they've completed endocrine-based therapies? And I certainly do think that there's a population, and I'm sure we'll get to that in some of the Q&A here. TROPiCS-02, which led to the approval of sacituzumab govitecan, TROP2 targeting ADC for patients with hormone receptor positive disease here, SG versus chemotherapy of physician's choice. We saw a significant but modest 1.5-month improvement in median PFS, and that translated to a 3-month improvement in overall survival. Heavily pretreated patient population. Neutropenia, diarrhea are the two big side effects that we think about here. SN38, the active metabolite of irinotecan, is the payload here with SG. Tropion Breast 01 looked at Dato-DXd, another TROP2 targeting ADC like SASI, but with the DXd payload like TDXd, looking at Dato versus chemo in patients with hormone receptor positive advanced stage disease. This was not as heavily pretreated of a patient population as TROPiCS-02, 1 to 2 prior lines of chemotherapy here, and again, a pretty similar improvement in median PFS of about 2 months. And then the overall survival advantage, there was not an overall survival advantage seen, but obviously this was developed in an era where we've got all these other therapies, and we very well might not see an overall survival advantage. Safety profile here is very distinct from TDXD and SG. So we're seeing a lot of stomatitis, mucositis, and eye toxicity, so ocular toxicity here. The stomatitis, mucositis can be quite significant, but steroid mouthwash can actually be very useful in this case and can mitigate some of these side effects. The dry eyes can certainly be challenging for patients, but steroid eye drops can also help there. And so Dato-DXd was approved in January of this year for hormone receptor positive advanced stage disease. So now we've got 3 ADCs that are approved for advanced hormone receptor positive disease.
So thank you so much, Rita. Heather, we're back to our survey, and I'll say that I'm not going to show any more data from the general oncology survey because the rest of the things really lined up with what the investigators saw. The only thing where we saw a big difference was Serena-6, which is kind of interesting. I mean, general oncologists have a lot of experience with, sort of borderline situations involving the patient. I just think it's interesting. That was the one area that was different. Anyhow, getting back to the investigator survey, Heather, one of the biggest areas of controversy has been the double mutant patient, ESR1 and PIK3 positive. in the second-line situation. We saw early on when we started to do these surveys that it depended upon the case, what people did. So we tried to tease this out a little bit. Of course, one of the key factors has been how long were they on the CDK inhibitor. So we actually asked in this survey some cases that were 2.5 years and others that were 10 months, less than the 1 year. So here's a patient relapses after 2.5 years, has not minimally symptomatic bone mets, and by far you see elacestrant being chosen, probably I think because of better tolerability compared to CAPI. Incidentally, anybody know anything about tolerability of the gedatolisib, the new thing being presented at ESMO? Does that have the same issues of PIK3? Hal, do you know?
It's got a little bit less, at least in the reports, but it's an intravenous medication, so it's less convenient for the patient.
Interesting. Anyhow, Heather, so 2.5 years, not very symptomatic. People go with elacestrant. When we move it up to age 80, even more people go with elacestrant. Again, I think you're thinking about tolerability, glucose, etc. Now we bring it down to 10 months, and you see people using CAPI fulvestrant. Also, if we do 2.5 years with symptomatic visceral mets, we see more people using CAPI. So, Heather, how does these practice patterns of your colleagues match up to how you think these things through?
Right. So I think that time frame of exposure to the first-line CDK hormone therapy combination is critically important in decision-making. If the exposure is less than 12 months, then I'm thinking that hormones are not what's driving the behavior of the disease, and I might be more quick to move on to other strategies. I might explore the PIK3CA, but I probably wouldn't do ESR1 as monotherapy. This co-mutation, we do talk about it a lot, but it's relatively uncommon. It's only seen in about, according to Komal-Javeri, 16% of patients. So it's actually not that common. I think that, to your point, we do favor elacestrant as monotherapy because it is extremely well tolerated. Whereas the PIK3CA targeting agents, as Rita pointed out, have the hyperglycemia issues associated, which can be more difficult to manage. So I agree with these responses.
So, Matt, Rita mentioned that imlunestrant was just approved in September, so now we have another option, two options as monotherapy. Most of the faculty say, I can't tell the difference between this and a coin flip, or how are you thinking through which one to use at this point, Matt?
Yeah, it's a great question. I look back to the data when the CDK4/6 inhibitors came out, and we all started using palbociclib because it came first. And then as time went along, we all said, well, there's tolerability differences, so I can pick the drug based on the tolerability. Then eventually we had longer-term data that suggested that there were differences in long-term survival. So I think right now we don't know. The imlunestrant trial studied a slightly less heavily pretreated patient population. Rita mentioned, I think there was still about 30% of patients with no prior CDK4/6 inhibitors. So we don't have as much data, I think, as we've sort of mined the data with elacestrant. But, I think as time goes on, we'll see. I think what we'd love to see is some survival data. And so that certainly could be helpful.
And also how well tolerated these agents are in general. We were talking about the Serena-6 study, and Erica Hamilton pointed out to me, we just did a program with her, that the quality of life started to improve right away as soon as there was a switch, and she thought it was because they were coming off the AI going on to TERD, which is better tolerated. So Hal, you actually, I think, did the discussion at San Antonio Ember 3, and interesting of our survey here, this is what we call a consensus, when everybody gives the same answer, which is, it seems like, we already thought about the issue of Abema, post-Monarch, as having some value, Abema after prior CDK. Now you're bringing in imlunestrant. You brought up in your discussion that, you apologize as usual for showing a slide comparing indirectly, but there were greater benefits. All of the investigators think there's a role for a combination of imlunestrant and Abema, or, I guess, SERD and AI. What are your thoughts now that you've had some time to think about it?
Yeah, so two things. One is, I think one of the takeaways from the SERENA-6 trial and the EMBER-3 trial is actually it's very tolerable to give the oral SERD in combination with the ongoing second-line CDK4/6 inhibitors. And if you look at those data, you're looking at somewhere between 10 and 12 months, almost a year PFS in that second line. So actually, I agree that I think the imlunestrant of abemaciclib combination looks like a reasonably active and reasonably well-tolerated combination that I would probably think about quite seriously in patients who've progressed on prior AI and CDK4/6. And again, in the EMBER-3 study, it looked better than some of the experiences we've had over the years with PIK3CA inhibitors in that subset of patients as well. So I think that may become a go-to strategy. It's not that we're monitoring as they do in SERENA-6. I share my colleagues' feelings on that point. But if you're progressing and if you're switching to an oral SERD, I think that continuing to CDK4/6, there's now 2 large randomized trials showing what looks to me like a robust outcome.
So going back to questions from the attendees, Rita, you were talking about alpelisib, and again, our way of doing things is we just say, are you using it or not? And when we ask people, most investigators say no, although there are like 20% of oncologists in the community who still use alpelisib. Are you using alpelisib? Another question I thought was interesting that came in is, what about the inavolisib triplet in a patient who has de novo disease? These are supposed to be endocrine resistant. Would you ever give it to a patient with de novo disease?
Yeah, I mean, I'm not using alpelisib in my clinical practice. I've really gone to CAPI. It's more tolerable in that. I think inavolisib, I haven't had a chance to use it yet. I don't know that I would necessarily use it in someone with de novo metastatic disease. I think that, certainly more side effects. But in the patient population that the Inavo trial enrolled, I absolutely would because of the survival advantage that was seen.
So, Heather, what about the patient who gets the triplet? And it's amazing how few people have done it, even investigators, as you said, Rita. But if you have a patient who gets the triplet as first-line therapy now, which is, approved, what would you do if in second line, do you need to rebiopsy and see if the PIK3 is still there? Would you give CAPI after the triplet, inavolisib triplet? Heather?
So, like Rita, the inavolisib triplet has never been prescribed yet since its approval across our UT Southwestern network, which is pretty large. So our group, not once. We just haven't seen the patients that were described in the Inavo 120 study, particularly those early recurrences. So full disclosure, nobody in our group really has experience with what the best approach is for that patient population since we haven't prescribed. But it is on the clinical trial, at least on the Inavo 120, it's an aggressive tumor type, and I would have probably a low threshold. I wouldn't expect a very long duration of response to the triplet because typically the duration of response in real world is less than that seen on the trial, and it wasn't terrific. So I would probably have a low threshold for moving on to chemotherapy.
Matt?
Just a comment, and I look back, 20, 30 years ago to some of the academic studies that were done in the metastatic setting, which examined the question, should you give combination chemotherapy versus sequential therapy? Because at the end of the day, I think the oncologists and patients want to know what is the best regimen, best sequence of therapy that's going to preserve quality of life and overall survival. The problem that I'm seeing with some of these studies is they're actually not allowing the patients in the control arm to get actually the therapy, so we don't know. So I think if the concern is that we keep moving on into endless doublets, triplets, quadruplets, quintuplets. We can't do that, right? So I think what we need to be doing as a field is asking the question of what's the best sequence? Maybe patients, for example, in the Inavo study, by the way, in that study, the patients in the control arm, I think there was just a minority, 2 or 3%, that actually got a PI3 kinase inhibitor. So we don't know what the best strategy is. And I think that's important. Now, if a triplet is better because it produces a huge improvement in overall survival, quality of life, and patients in the control arm are eventually getting in the case, the study drug, fine, we should do that. I think we need to make sure that we're addressing the issue of study design.
So, Rita, a lot of questions about using PIK3 inhibitors, including capivasertib. And one issue has been the issue of glucose tolerance. We actually had a case that was presented to me from a general oncologist. She said, I put the patient on Cappy, but she had a lot of problems with glucose, and I had to take her off after a couple of months. And I said, what was her hemoglobin A1C? She said 7.2, and I sent the patient to an endocrinologist. By the time the patient got to the endocrinologist, they were already having severe problems. Here's a case that was sent in, a patient who has mild hepatic steatosis. Hemoglobin A1C is borderline. This is not, I don't think full-blown diabetes or, pre-diabetes. Do you hold off and try to control their glucose first, or do you start both? Do you need to have an endocrinologist involved? Do you do continuous glucose monitoring? And what's your experience with quality of life issues on Cappy?
Yeah. It's interesting. I have one of my partners is working on a study to try to push the hemoglobin A1Cs with Cappy IIT. So we're going to be doing continuous glucose monitoring and intervention in these patients. So I think that's going to be really helpful because at the University of Chicago, I have a lot of patients who come in who are not going to tolerate drugs like alpelisib and Cappy well. I have to say in this patient, I would be inclined, just given how minimal her disease is, how long she was on an AI CDK4/6 inhibitor-based therapy, to consider putting her on elacestrant and then maybe working on her hemoglobin A1C in anticipation of a subsequent line therapy if we could get to like Cappy plus fulvestrant. Recognizing there's not data, but that's probably what I would do. The other thing I do want to comment, we were talking about quality of life, and I think Matt raised a really good point about some of these. I've had patients who are just so miserable on these PI3 kinase AKT inhibitors, and then when we ultimately transition them to chemo, they feel so much better because their quality of life on some of these therapies are so challenging. So I do think it's very important to think about quality of life in patients on some of these therapies. And, my patients this is just not the life that I want to live. This isn't even worth living for me. So I think there's a lot of that. So I think just getting back to this patient, though, I'd probably start with elacestrant, try working on her hemoglobin A1C, maybe metformin or some other agents in anticipation of potentially offering her Cappy down the road.
Also interesting, you have a lot more experience preventing and ameliorating toxicity of chemo than these new agents. So sometimes it takes a few years for people to sort of figure out how to do things, and that's really the stage we're in with a lot of these drugs in the ER-positive space. So how ADCs in hormone receptor-positive disease, now we have 2 TROP2 ADCs, and of course in HER2-low TDXD, breast cancer. We see ADCs all across oncology and hematologic oncology, but they're more, I think, in breast cancer than anywhere else. Here we'll begin with some questions. How TROP2 ADC after TROP2 ADC, any situation where you can see doing it? Maybe they've gotten sassy in the past, they've gone through a couple other things. Would you try Dato?
Every patient we're seeing in clinic is getting multiple ADCs at this point. They're all trying trastuzumab deruxtecan, and they're trying sacituzumab govitecan. I so far have found those to be better tolerated drugs than the Dato DXD. The eye toxicity and some of the other side effects of Dato make it a less appealing choice for many of my patients. I don't think we have any idea which is best. They're going to be yet more data for Dato at Berlin next week because they just announced Tropion 49 or whatever it is.
They're only up to 2.
Triple negative disease, it outperformed chemotherapy. So look, the class of drugs with these irinotecan type chemotherapy payloads, whether it's linked to an anti-HER2 antibody or to a TROP2 antibody, is in general more active than chemotherapy. Full stop. Which one's best? How to sequence them? Is there a molecular marker? Short answer, no. We don't have any idea. So you're basing it on clinical tolerability and side effect profiles. And that's what we're doing. Trastuzumab deruxtecan for many patients is every 3 weeks, which is a little more convenient. You have to be worried about the pneumonitis. We still see the pneumonitis sneaking up on people. But SG, there's more diarrhea, there's more neutropenia, so you have to use the prophylactic GCSF. And Dato, the eye toxicity and other issues, I find make it a little less appealing.
So Matt, it's interesting Hal brings up eye toxicity. We did a whole program just on ocular effects, and actually there it was much more other ADCs, mirvetuximab, belantamab, and myeloma. Yes, there is corneal toxicity with Dato, but my impression, what I've been hearing is very minimal. Hal, you've seen significant problems?
Small sample size, it's been more of an issue in the folks I've treated so far.
That's interesting because I haven't heard too much. Anyhow, I'm curious, Matt, What have you seen with data, and not just in terms of corneal toxicity, which again, my hearing is pretty minimal, but also mucositis? And I've heard more about that. Any thoughts on how and quality of life, how would you, and getting back to now you have SASI or Dato, really in this very similar space. How do you choose? Is it based on toxicity? There's a different schedule. Dato's every 3 weeks. SASI, you have to come in more frequently, maybe get growth factors. What's your experience with these two, and how do you decide right now, Matt?
So my experience with Dato-DXd is still minimal, and I think I'm really excited to see the data that's going to be presented at ESMO. I would say this, and that is that we need as a group to put our thinking caps back on, and when it comes to endless Topo-1 ADCs. And what do I mean by that? At the end of the day, a lot of these drugs, they might have a different way to get into the cell, but it's the same mechanism of action. And so remember, we still have all these other classes of drugs. What about the taxanes? What about the anthracyclines? Again, we think about these drugs in terms of their name, et cetera. But we also have to remember what the payload is, and also getting back to that question of what's the best sequence. That's still, I think, a major question. Now, at the end of the day, if you look at the data for these ADCs, we're seeing data that compared to physicians of choice, they're better. I think that's clear. But what's the best sequence afterwards? Is it best to go on to another ADC, or is it best to go on to a taxane? Those are the questions I think we as a group need to address.
So, again, Heather, I remember we did a CME program like the day after the HER2-low data were presented a couple years ago at ASCO, and we were already talking about sequencing there in terms of the options. And of course, here in ER-positive disease, you have the option of TDXD in the HER2-low patients and a TROP2 ADC. How do you make that decision? We'll talk later about triple-negative, but what about ER-positive? What comes first in general in HER2-low patients?
Usually for the HER2-low patients, I use trastuzumab deruxtecan first and then go on to a TROP2 ADC. I would just make the comment, and so I'm the global PI for the neoadjuvant Dato-DXd study for triple-negative disease. So I can reassure the audience that the eye issues are relatively uncommon, but it does require quite a bit of management in that my recommendation is to use the steroid mouthwash from day one. You have to use it 4 times a day. You have to use the eye drops 4 times a day. Ice chips during infusion. So it is a little bit more day-to-day management. So I do think that as we compare these studies, and I think next week when we see the ESMO first-line stories of Dato-DXd and sacituzumab in the PD-L1 negative, triple-negative breast cancer experience, I think we will naturally be comparing the magnitude of the benefit, but also the toxicity profile, and I think that those impressions will filter into other spaces such as this.
I've heard that using the prophylactic mouthwash really is effective in preventing the mucositis, and that the mucositis can be really problematic. That seems like more of an issue than the eye.
Once it occurs, it's terrible. It's terrible. So we've actually partnered with a company that makes what they call a chemo mouthpiece. That's been very effective in people who have had issues despite all the prophylactic recommendations. It seems to work very well. But once it occurs, it's really a problem for patients.
Yeah, I've heard of patients do the mouthwash, they're doing great, and they decide to stop it because they're doing so well, and then they have problems. So I think it's really important from a patient education point of view. So Rita, we saw some data, I think maybe we're going to see it later, but about re-challenge with TDXD after pneumonitis, mainly grade 1 asymptomatic.
Yeah.
What are your thoughts about it, with your experience about it? In what situations will you re-challenge?
Yeah, I have to say I have not had that opportunity. Most of my patients have grade 2. They'll have a little cough or a little shortness of breath, and it's really hard to know, is that just chemo or is that the pneumonitis? But, I haven't really honestly seen a grade 1. I think I would. I think it would depend on the situation, on the patient, how well they're responding to the therapy, what other options they've got, I think. But absolutely, I would consider re-challenging for a grade 1.
So before we go on to our next topic, 2 more quick questions. Matt, can you use TDXD in a patient with decompensated heart failure, EF of 35%? And we're going to talk later about triple negative, but we already brought up ultra low, where we don't have any data with hormone receptor negative would you use TDXD in in a hormone receptor negative ultra-low patient? And again, what about the heart failure thing?
I think the heart failure issue is interesting. I haven't run across much of any issues with the heart with TDXD thus far. It'd be interesting for my colleagues. The incidence obviously was very, very low, and so I think in a patient where I think that they would clearly benefit of the drug, and I would do very careful monitoring. I don't think there would not be an unreasonable reason why I would not do that. Obviously, it hasn't been looked at carefully in studies, but we would have to approach it with great caution. But again, it's not that I would never say I would never consider it. And then could we treat patients with hormone receptor negative, HER2 ultra low? And I think that's what we're seeing with TDXD, of course, is that the drug has activity. Really, we haven't been able to find a HER2 cutoff as of yet that suggests that the drug doesn't have activity. And so certainly I would consider it.
So if you think we're going fast, just keep in mind we're going to actually spend 6 hours on the same content when we go to San Antonio. So you get through 3 straight nights, we're going to spend 2 hours in a row just on what we're talking about right here. So maybe this is sort of a tasting menu to be continued. And particularly as it relates to HER2 positive disease, Hal, we could spend a whole hour just talking about that, but let's talk about it.
Great. Well, first, it's fun to be with the Florida Cancer Specialist Group. This is the time of the year when about half of my practice seasonally migrates down to your clinics, and so I am grateful for the care you often give them. I feel like I could walk down the boardwalk in Naples and wave to a whole number of my patients come January. So maybe I'll get a license and try and bill for those visits at some point. HER2 positive disease, obviously a great story in breast cancer and ongoing data coming forward. The key thing to watch here is that really we're talking about the big innovation is in trastuzumab deruxtecan. It began in refractory disease. It then became the standard in second line. It's now becoming a standard in first line, and now it's moving to adjuvant after resistant disease and even neoadjuvant. And there'll be more data from the meetings next week. I'm actually showing you more slides from the Wall Street Journal of Medicine than from the New England Journal of Medicine. So take that for what it's worth. In the preoperative setting, the standard of care is to give preoperative chemotherapy, trastuzumab, pertuzumab, for HER2-positive stage 2 or 3 disease. We've seen data this past year that this is a very active regimen class, THP or TCHP, with PCR rates on the order of 60 to 65%, always more in ER negative than in ER positive. So the data that we're going to see next week at ESMO are the Destiny Breast 11 trial, which is a preoperative therapy for HER2-positive disease, comparing TDXD versus a sequence of TDXD followed by THP versus anthracyclines followed by THP. Now, when's the last time anybody here did not give or gave an anthracycline regimen in the pre-op for HER2-positive? Okay. 1.
2, right?
Pretty rare. And so usually we've been using TCHP. So that's the missing arm in all of this. What we know from the press release from the company in May is that TDXD followed by THP was better than AC followed by THP. They also said that TDXD by itself was not. So your scorecard currently looks like this. TDXD monotherapy will not be the standard. Perhaps TDXD followed by THP. There may still be a role, apparently, for my 2 colleagues here, but they're the only ones in America still giving anthracyclines in this setting. At least I'm not. Except for cases of like HER2 ambiguous tumors where you sort of want to use it. So we'll be very interested to see that as those data emerge. The other exciting new space is going to be the space of residual HER2-positive disease after neoadjuvant therapy. The Catherine study was well known to all of you, where patients were continued on trastuzumab monotherapy versus switch to TDM1. Very long-term follow-up just published in the New England Journal of Medicine shows a survival benefit at 7 years for using TDM1. What we saw in Destiny Breast 05 press statement is that patients who had HER2-positive residual disease in lymph node after neoadjuvant chemotherapy, again, randomized to TDM1 versus TDXD, and your press statement from September showed that TDXD, again, improved invasive disease-free survival in these patients. So the question will be, is it better to use the TDXD up front or to save it in the salvage setting? We won't know. It'll depend a little bit on the eye of the beholder, I think, as to how much improvement you're really seeing in that rate of PCR and whether there's some groups that benefit or not. But TDXD is now part or going to be part of your standard early stage regimens, I think, for stage 2 or 3 breast cancer, either upfront or in the residual disease setting. There's older data still for neratinib, which was used in the Extenet study. This was a study that predated the availability of pertuzumab, TDM1, and now TDXD, so you have to wonder how germane these data are to our contemporary practice. But in one study where they added a year of neratinib after a year of trastuzumab, there was a reduction in the risk of recurrence, particularly in ER-positive breast cancers. They've actually now published longer-term follow-up with that drug. There's no survival benefit for this drug. And I rarely use this in any patients given the availability of other drugs that we now routinely have. So now we're switching gears and talking about metastatic HER2-positive breast cancer. And again, what we've seen in recent years has been TDXD sort of walking up the ladder. And so what began in refractory disease has now moved into second line. And then what we saw most recently at ASCO 2025 was the Destiny Breast 09 trial, which looked at initial therapy for HER2-positive metastatic disease with TDXD versus TDXD plus pertuzumab versus THP. Now, as Claudine Isaacs pointed out very brilliantly in her discussion, there was a bit of a fudge factor here because the TDXD pertuzumab was used until progression, but the THP was only used for about 6 cycles. So the endpoint of progression-free survival really isn't a fair comparator. It's not that the drugs don't work here, but they stopped the chemotherapy part of the THP arm and just switched them to maintenance HP. Now, of course, that's what we all do in clinical practice anyway, but it left open this question as to whether you should be continuing TDXD indefinitely or taking a maintenance approach, which we don't know the answer to. Here are the key data in terms of progression-free survival. There's improvement with ongoing TDXD pertuzumab compared to THP, but remember at that first hash mark there at 6 months, they stopped the T. So it's really just comparing maintenance therapy versus ongoing THP beyond that. There's a whole bunch of data here. The response rates were quite robust in each group at about 80 to 85%, slightly numerically higher for the TDXD pertuzumab arm. If you look at overall survival at the time of the analysis, there was no evident benefit. Again, to Matt's point earlier, to Rita's as well, looking at crossover and making sure the accessibility of these drugs is really important, especially in these global trials. We've all been using TDXD for years in refractory disease. Every one of these patients should have access to that drug at some point, and we don't know when the best sequencing would be. They tried to do an analysis of time to second progression. It's all really complicated because of the heterogeneity of practice that you see in the table on the right. Again, you can't escape the pneumonitis, so you just have to constantly keep your team aware of it. You also have to keep your referring physicians aware of it. I got a call a few weeks ago from an emergency room in western Massachusetts with a patient who had shortness of breath, and pneumonitis was not on their list of possible side effects for TDXD because they just don't see this drug all the time. So you have to always be reminding people to think about it. Before I get to the discussion of brain mets, where do I think the DB09 data suggest? For patients who've previously had a lot of treatment in the early stage setting, they've often had a taxane, they've had trastuzumab, they've had pertuzumab, I think TDXD is the go-to drug. We use it for a while until we get a good response. Then personally, I usually switch to a maintenance strategy of trastuzumab, pertuzumab, and if the tumor is also ER positive, I introduce endocrine therapy, and sometimes we're even giving endocrine therapy with palbociclib based on the recent patina data, which show that patients can often go 2 years at least on maintenance treatment with endocrine therapy and the CDK4/6 inhibitor. In patients who have more overt crisis of brain metastases, visceral disease, TDXD to me looks like a better drug, and that's where I would usually start the treatment. What about brain mets? So there's been a lot of interest in this going back to the very first description of trastuzumab for metastatic breast cancer. They started showing back then that there was a greater incidence of HER2-positive disease before having brain metastases. It was probably a consequence of 2 things. One is it still remains a relative sanctuary site in some respects. And the second is that patients were finally living long enough that they lived long enough to develop metastatic disease to the brain. Now we think this is a very common problem, and this is just some data from my colleague Sarah Sammons making the point that for HER2-positive breast cancer, roughly 30 to 40% of patients will, in the course of their disease, develop brain metastases. Actually, a very similar number if you live long enough with triple-negative breast cancer. So we've seen that there are newer drugs that clearly have activity in the brain. They include TDM1, which has been shown in multiple studies and subset analyses to have activity in the brain and to outperform standard chemotherapy in that respect in patients who have brain metastases. We also know that tucatinib on your left and TDXD on your right can improve outcomes in the subset of patients who have brain metastases. If you compare, as they did in DB03, TDXD versus TDM1, there's a higher response rate in that subset cohort of patients who have brain mets with TDXD than with TDM1. And so the story here is first that these drugs have activity in the brain. And the best way to find drugs that work in the brain is to find your best drug that works outside the brain, because there actually is there's no such thing as a blood-brain barrier. They've been looking for it for 200 years under the microscope. They can't really find it, especially in patients who have metastatic cancer. The problem has been that the drugs aren't very good, and patients who get brain metastases often have refractory disease. So my colleague Nancy Lin has been the pioneer here, and I have coined the eponymous Nancy Lin rule, which is the best drug for brain mets is the best drug that works outside the brain. There's no point doing drug discovery uniquely for brain metastases. You just look for active drugs elsewhere. And that's what we've seen with these products as well. The second point is these drugs are now active enough that in patients who have limited metastatic disease to the CNS, we actually often start with drug therapy, try and hold off, particularly whole brain radiation, as long as we can, though newer studies do suggest you can do up to 10 foci of SRS or gamma knife treatments, and the patients do better than with whole brain. So brain metastasis is a challenge, but our drugs are working better, and we don't know which is best. Since most patients are getting TDXD in the first or second line, the utility of all these other drugs downstream is much less well characterized, and that does become a clinical challenge. Matt and I and a few others in the room here are old enough to remember there are older drugs that work in the brain: capecitabine, anthracyclines, endocrine therapy. These are all drugs which have activity in the CNS as well. Finally, a niche population of patients who have HER2 mutations in their tumor. So these are not HER2 new gene amplifications, but they are point mutations. You often find these when you're doing liquid biopsy or other genomic sequencing on the tumor. Interestingly, they are particularly enriched in metastatic lobular breast cancers, where roughly 5 to 8% will harbor such a mutation. Overall, it's 3 to 5% of hormone receptor positive metastatic disease. So actually, there's a lot of data on what to do for these kinds of tumors. They tend to have mutations which affect the kinase domain of HER2, and there have been studies that have looked at a variety of different treatments. The tyrosine kinase inhibitors like neratinib and tucatinib do have both monotherapy treatment outcome responses, and you can use them in combination with endocrine therapy. Here's a report that looked at neratinib in combination with fulvestrant. They've also shown that neratinib in combination with fulvestrant and trastuzumab has reasonable activity in this small subset of patients. Tucatinib and trastuzumab has been shown to have response rates of about 40% in patients who harbor this mutation. And finally, of course, TDXD has been studied here. You probably have already used TDXD in HER2-mutated lung cancers and other situations, but in the metastatic breast cancer response rate group, it's about 50%. So all of these drugs which target either the tyrosine kinase activity or HER2 more broadly will have activity in this subset of patients with HER2 mutations as opposed to gene amplifications. And I think that's it.
Awesome, Hal. So, Matt, we have like an office poll when we do a webinar about how long it's going to take for somebody in the chat room to ask about cell-free DNA. So here it was about 7 minutes before we had 2 questions. I always love asking the breast people. So, and we're going to, obviously, we'll talk a lot about it in our colon program in a couple of hours. And a couple people were bringing up in terms of decisions about whether to use CDK and every other, including metastatic disease. Any thoughts?
So in terms of using cell-free DNA in the metastatic setting, is that the question?
No, any setting in breast cancer.
I think what we're, in my practice, and my colleagues can probably say this as well, but one of the things we know about ER-positive breast cancer is that there's great plasticity. And so in patients that progress on a CDK4/6 inhibitor, the clones that emerge really are vastly different than those that we started out with. And so I think that's where we find great utility of assessing for ctDNA in the metastatic setting in ER positive. In triple negative, I think there's sort of less plasticity. Now, you start out with triple negative, you stay triple negative. There may be a few exceptions, but so in the metastatic setting, ER positive, certainly. I think where we're going to begin to see more, I think, quite interesting data is as we begin to incorporate the role of CDK4/6 inhibitors, specifically palbociclib, based on the data that has been presented, the Alliance Foundation study looking at the role of palbociclib in HER2-positive breast cancer. So again, all of a sudden, we begin to see that these luminal HER2-positive breast cancers we're going to probably see some of the same plasticity and alterations, ESR1, PIK3CA mutations, et cetera. It's going to raise a whole set of questions about what can we bring those drugs into that setting as well. Obviously, we have lots of very effective therapies that target HER2, but these are certainly areas that I think about utilizing cell-free DNA.
Okay, let's get back to HER2-positive disease. And as Hal mentioned, this is going to be the presidential symposium actually a week from today. We'll see the neoadjuvant trial, DESTINY-Breast11, but also the post-neoadjuvant residual disease trial as well, and this really interesting session next week, which leads to a pretty simple question, Heather. What's your approach to first-line therapy right now? At least ideal, let's put aside a regulatory. What do you think is the ideal approach? What do you think about how? I haven't heard this idea of focusing more on people with heavily pretreated disease. I was going to ask him, what about TDXD and de novo HER2-positive disease, or more with brain mets? How are you thinking it through? How are you thinking it through maintenance?
I think I'm pretty aligned with what Hal described. So for my patients with ER-positive HER2-positive disease, for the most part, I'm still treating them with induction THP and then maintenance and folding in the palbociclib, given that really impressive patina data. And that was a labor of love. So hats off to Otto Metzger for getting that trial done, because that took a long time to do the patina trial. But it was so impressive, the data from that. I haven't pivoted to administering TDXD in the first-line setting for that patient population. For the ER-negative HER2-positive population, I'd be more inclined to use the DB09 approach with TDXD and pertuzumab because I don't have that endocrine therapy option to fold into the maintenance component. Whether I would treat with TDXD, and again, this is sort of a new space for us, whether I would treat with TDXD, pertuzumab indefinitely, I would reevaluate on a case-by-case basis.
So, Rita, any details in terms of how you're going to think throughout? We have this way of just asking people what they do. Within like a month of the patina presentation, when we surveyed investigators, everybody was using Palbo. And I see everybody shaking their head here. Also, what the future holds for endocrine therapy in HER2-positive disease beyond CDK. Are we going to see PIK3 inhibitors in that space, et cetera, et cetera? How are you approaching first-line therapy and particularly duration of TDXD? Yeah. Is the patient tolerating it well, or would you continue it or stop at an arbitrary point?
Yeah, I think it's an interesting question, and I haven't quite gotten there yet with the patient. But I agree with Heather in terms of the hormone receptor positive patients. THP is a great therapy, and to be able to offer them that quality of life when you transition to the patina regimen, I think is great. I think if patients have brain mets, it's a no-brainer. I'm going to start with TDXD regardless of whether they're hormone receptor positive or not, because again, you want to control that CNS disease. I think for the hormone receptor negative patients, I do think I would be inclined to start with TDXD, but I don't know that I'm going to want to continue it forever. And I think at some point I'm going to want to transition to maybe adding trastuzumab in there and keeping the pertuzumab going. And whether that's, X number of cycles or it's to get to a good response and then keep maintenance going. But I think all of us have patients with HER2-positive metastatic disease who are cured of their metastatic disease. And so the idea of continuing something indefinitely without the opportunity to potentially stop therapy, and I've done this in many patients. I'm not saying I do it right away. It takes years and negative PET scans and negative ctDNA, which I do in this setting. But, I think we need to think about that too. And so continuing therapy indefinitely, especially with TDXD and that ILD risk, I think is not something I'm looking forward to.
Interesting about the idea of cure of metastatic disease. Heather?
I think tolerance would be a big factor in that decision. So I inherited a patient from Shanu Modi who was on DB01, the first study. She was on TDXD for 7 years, no symptoms, and we debated about taking her off every time I saw her and switching her to a trastuzumab or pertuzumab-based regimen. And she just didn't want to come off because she was tolerating it so well. I had another patient who had 2 doses of TDXD with all the appropriate, you have to have at least 3 prophylactic antiemetics, despite good prophylaxis and a lot of attention to her management. After her second dose, she said, I don't care if this is the best drug that you have available, I never want to see it again. So I think our decisions about duration of TDXD treatment will be directly dependent on patient tolerance.
Good that you brought up the GI issues. Where does olanzapine fit in with the TDXD patients for you, Heather?
It works really well.
Yeah.
That's what I keep hearing. All right. Well, Hal, you talked about these things, the trials we're going to see next week. I've already in my mind figured out how I'm going to think about it even before I see the data. I'm sure you have too. And certainly the residual disease thing versus TDM1 looks pretty straightforward. We've already seen that in the second line setting. TDXD really was much better than TDM1. So it'd be interesting to see what the brain met situation, because I guess, Catherine, really you didn't see a decrease in brain mets as far as I know with TDM1.
Yeah, I mean, it's sort of a post hoc look at that. So there are all these secondary endpoints. I think you're right. If you look at the Destiny trial that compared TDXD versus TDM1 in the second line, it's a pretty clear win for TDXD, so it's no surprise that the DB05 data are reported as better. I've genuinely not seen the data. I know that a lot of the people you see up here say things like, I haven't seen the data, but I guess the response rate is 72.694%. I've actually not seen the data. Look, the benchmark should be about 70% PCR. If it blows that out of the water, I think it's going to make a strong argument for TDXD in the neoadjuvant setting. These studies are all way too big. They're all way overpowered to look for statistical significance, even on things that are more modest of clinical benefit. And so if it goes from, 67% to 69% with a p-value of 0.01, I don't know that that's so compelling for everybody. Maybe you'll save it for the folks on the backside. If it goes from 69% to 92%, I think it's game over, and that would be fantastic to see such an outstanding rate of pathologic complete response. The other thing just to remember about the metastatic treatment is that in America, you shouldn't be seeing that much recurrent HER2-positive metastatic disease. The incidence has plummeted because of the efficacy of adjuvant trastuzumab, the salvage with TDM1. If you look at the trials that are accruing globally, the majority of these patients have de novo metastatic disease. In part, that's because HER2-positive is a more virulent flavor of breast cancer when untreated, and in part it's because they don't have screening mammography and early detection programs or adjuvant treatment. So the population you see in Florida, where the patient had stage 1 breast cancer, got TH therapy and recurred 4 years later, or had stage 2 or 3 and got TCHP and then a year of HP or whatever and recurred 4 or 5 years later, is really pretty different than the population that goes on to these trials. And that's where the extent of prior therapy, the biology of the tumor, and those kind of choices may influence your treatment.
I think this neoadjuvant versus post-adjuvant also is going to be, like everything else, influenced by concerns about ILD. And if you use it neoadjuvantly, more people are going to be exposed than if you wait and see if they have residual disease. But again, as you say, if their path-CR rate is outrageous, then, obviously you can screen for ILD, and hopefully it won't be a problem. Heather, any thoughts about neratinib? It's interesting how strong the effect is in ER-positive patients, and Hal brought up the caveats about when the study was done. We had questions about tolerability of neratinib, the dose escalation approach, and preemptive use of antidiarrheals. Have you used neratinib? Are you using any in your practice, and how do you find it tolerated?
I use it rarely, typically in my younger patients who have very high-risk disease, ER-positive, node-positive, where I'm inclined to do more. I suspect I wouldn't consider that after I see the data next week, though. And we also have other studies in this space, like the Flamingo HER2 vaccine trial, which is a phase 3 trial that's ongoing and enrolling globally. So in very, very select patients, I'd say I probably do that only once a year, prescribe neratinib, and that might be a phenomenon of the past as of next week.
And do you do dose escalation and preventive antidiarrheals if you're going to use it?
I don't. I start at full dose and just manage and anticipate the diarrhea up front. Although that would be a totally appropriate and data-driven approach to do that, of course.
So, Matt, again, a question we've been asking the last few years that we're seeing the answer to this question shift, which is how do you approach patients who are HER2 positive with brain mets, particularly in the second-line situation. There's a lot of excitement about the HER-Climb approach earlier on. But now, again, when we poll people, what we're hearing now is TDXD. How are you approaching brain mets?
I have to say that I've had phenomenal responses to TDXD, and I think, as Hal said, I love that phrase. If a drug works in the systemic, it going to work in the brain. I think one of the questions that's coming up for me is, and commonly now, is if you have patients who have leptomeningeal disease, when do you actually introduce the drug? I mean, commonly it's craniospinal irradiation therapy, but maybe we should actually be incorporating that TDXD into that sequence of therapies as well. But certainly, I just had a patient recently with a phenomenal response with leptomeningeal disease to TDXD. So I think that this is clearly the most active regimen, and it's one that I find that I'm going and using more and more.
So we're going to go on in a second, but Rita, Hal talked about HER2 mutated disease. As he was saying, we talk about this all the time in non-small cell lung cancer, first-line therapy, TDXD, and HER2 mutant disease, but also we've seen activity with neratinib. How do you think through management of these patients? Have you used neratinib in HER2 mutant disease?
I have not, because I found a lot of patients who have HER2 mutations also have HER2 expression, and so I've used TDXD in these patients. I absolutely would consider it subsequent to that, but I haven't had that opportunity.
All right, we're going to move on now, talk about triple-negative breast cancer. Like everything else we're talking about, it's going to be maybe a different discussion next week, but let's see where we are today, Heather.
Thank you. So we're going to focus on ADCs, and we'll start with the TROP2 space. So TROP2 is an excellent therapeutic target because it's broadly expressed. It's a pan-epithelial cancer antigen that's overexpressed in all breast cancer subtypes, which you can see here. I've boxed in the first red box is the triple-negative by conventional definition, and then the box on the right is the ER-negative HER2-low population. TROP2 is a marker of poor prognosis and portends a more aggressive tumor that tends to be resistant to chemotherapy. But its ubiquitous expression is what makes an excellent therapeutic target. So there are currently 3 TROP2 ADCs in this space: sacituzumab govitecan, datopotamab deruxtecan, and sacituzumab tirumotecan. They all target TROP2, of course. They all have topo-1 inhibitor. They have different payloads, but they're all topo-1 inhibitors. They have the proprietary linker cleavage. They have high drug-antibody ratio. That just means that you can get much higher drug doses to the cells of interest than you could ever give intravenously, and have shown a lot of promising clinical activity, which we'll review here. So ASCENT really was the first phase 3 trial that showed us how active these drugs could be in this space. So it was a study that enrolled patients with heavily pretreated triple-negative breast cancer who had received at least 2 prior lines of chemotherapy. They were randomized 1-to-1 to receive physician's choice of chemotherapy versus sacituzumab govitecan at 10 milligrams per kilogram, days 1 and 8 every 21 days. The primary endpoint for the study was progression-free survival, which you can see here at the top. You can see an impressive hazard ratio of 0.43 for progression-free survival, with an improvement from 1.7 to 4.8 months. And indeed, that progression-free survival benefit did translate into an overall survival advantage, 6.9 versus 11.8 months. And as a consequence, this became a standard of care for the treatment of triple-negative breast cancer. They did an exploratory post-hoc analysis looking at the benefit by TROP2 expression. So they lumped tumors into low TROP2 expression, medium, and high, and they saw very consistent benefits in favor of sacituzumab govitecan for all levels of TROP2 expression, and this is really why we don't measure TROP2 in the lab as standard of care. So ASCENTO-3 is one of the studies that we've been alluding to that's going to be presented next week at ESMO. This is a study looking at sacituzumab versus physician's choice chemotherapy in the first-line setting for metastatic triple-negative breast cancer that is PD-L1 negative. And we've seen the press release in May that says that the study met its primary endpoint for PFS favoring sacituzumab govitecan. So more to come on that next week. Javier Cortez is presenting that abstract. Now moving from sacituzumab govitecan to datopotamab deruxtecan or Dato-DXd. The Tropion Pan-Tumor-1 study was the first study that showed us that there was activity with this agent in the triple-negative space. There were multiple cohorts here, but there was a triple-negative breast cancer cohort. The primary objective here was safety and tolerability. But they did show a very promising activity with this agent in this setting, heavily pretreated population. This is a very, in my mind, impressive waterfall plot. And what you can also see here, you see these little asterisks that are underneath some of the columns in the waterfall plot, which references prior payload exposure. So most of these patients had received prior sacituzumab govitecan. So this speaks to the sequencing question that we were just trying to address, that yes, this is an active agent after sacituzumab govitecan. And interestingly, some of these patients also had DXd as prior therapy. So the payload, despite exposure to the same payload, drug is still active here in this form. TROPION-Breast02, very similar to the ASCENTO-3 study in that it has enrolled patients with metastatic triple-negative breast cancer who are not candidates for PD-1, PD-L1. In the first-line setting, patients are randomized to Dato-DXd versus investigators' choice of chemotherapy, and we saw a press release just a few days ago that this was also a positive study, that it met statistical significance for the two primary endpoints of overall survival and progression-free survival, and it was just added to the list of late-breaking abstracts being presented at ESMO next week by Rebecca Dent. So it's ASCENTO-3 versus TROPION-Breast02. They're looking really at the same space, and it'll be very interesting, as we mentioned earlier. Although cross-study comparisons are discouraged, we will naturally, I think, be looking at the efficacy data from those two studies and weighing it against the safety profiles. OptiTROP-Breast01, so this is looking at that third TROP2-directed ADC, sac-TMT. So this is a study that enrolled patients who had had at least 2 prior lines of chemotherapy, randomizing them to receive sac-TMT, which is given every 2 weeks, versus physician's choice chemotherapy. Primary endpoint, progression-free survival by BICR, which you see here on the left. A notable improvement in progression-free survival with a hazard ratio of 0.32. And once again, that progression-free survival benefit did indeed translate into an overall survival advantage. So another promising TROP2-directed antibody-drug conjugate. So this is getting to be very dense space. Now, the other big innovation in the triple-negative breast cancer space has, of course, been immune therapy. Should we be combining immune therapy together with these TROP2-directed ADCs? In the Begonia study, which was sort of an octopus trial, had an arm looking at the combination of Dato-DXd together with durvalumab and showed impressive waterfall plot here. This was all in the first-line setting, overall response rate of 79%. So this does seem to be a promising strategy and is being interrogated in other settings. So the TROPION-Breast05 study is looking at Dato-DXd plus or minus durva versus physician's choice chemotherapy in the PD-L1 positive metastatic space, so going head-to-head against Keynote 355, and more to come on that. The Ascento 4 study is a study that was just presented at ASCO, this past ASCO. This enrolled patients with PD-L1 positive triple-negative breast cancer and randomized them to receive sacituzumab govitecan with pembro, again going head-to-head against the Keynote 355 regimen, so physician's choice chemotherapy with pembro was the control arm. Primary endpoint, progression-free survival by BICR. Notably on this study, patients who experienced progression on the control arm were offered crossover to second-line sacituzumab govitecan in alignment with our current standard of care, and the implications of that you'll see in a minute. I just wanted to point out a couple baseline characteristics from this study. About a third of patients on study had de novo metastatic disease, and only 4 to 5% of patients had prior PD-1 or PD-L1 directed therapy. So this is not a population that represents your progressors after curative intent Keynote 522. This is essentially an immune therapy naive population, so just keep that in mind. But here is the data, progression-free survival. Notable improvement from 7.8 to 11.2 months. So again, this was the primary endpoint with a hazard ratio of 0.65 and a benefit that was very consistent across all of the subgroups that were interrogated, with the exception of the prior exposure to PD-1, PD-L1 therapy. The numbers were just too small. Again, only 4 to 5% of patients had received prior PD-1, PD-L1 therapy. So not surprisingly, that confidence interval is huge there. So notable progression-free survival advantage did not translate here into an overall survival advantage. But remember, for patients treated on the control arm, they were allowed to cross over and receive sacituzumab in the second-line setting. And so that might undermine any survival analyses. More to come on this component of the story because the data for overall survival was not yet mature. The maturity rate was only 26%. So we'll see how this unfolds over time, but it might be that there's never any survival advantage to be seen here. The most common adverse events are the same as what we've seen in other studies that were previously described, the neutropenia and fatigue being most common. And when we look at the adverse events of special interest, no signals there with the combination. Notably, the hypothyroidism and hyperthyroidism was much lower with the SG and Pembro combination than what we have seen on other studies. Usually hypothyroidism is about 15 to 20%. Here it was only 2%, so not sure whether that reflects increased vigilance and earlier intervention. Worth noting that there are other studies that are ongoing. The SASI-IO study is enrolling patients both with triple-negative breast cancer and hormone receptor-positive breast cancer and randomizing them to receive SASI with Pembro versus SASI alone, and more to come there. Now, and sorry, I'm going over a little bit, but moving on to the HER2 low space, it predominantly affects patients with hormone receptor positive disease, but there is a small subset of patients with triple negative disease who have HER2 low disease. We already heard about the Destiny Breast 04 study. It did allow for patients with hormone receptor negative disease, but they were only 10% of the population participating in this study. Here's the data for this subset. It's an exploratory endpoint, so not a primary endpoint, but you can see a very consistent benefit from what we've seen in the hormone receptor positive subgroup is seen there too in HER2 negative, in the PFS and overall survival. We talked about, there was a great question from the audience about HER2 ultra low disease that's also hormone receptor negative. The Destiny Breast 15 study is ongoing and has a dedicated cohort to that space that will enroll 50 of those patients, so more to come there. Sequencing we've touched on. We only have retrospective data that in my mind tells me just put your best foot forward, the drug that you think is most likely to work. But if a person doesn't have a great response to first-line ADC or upfront ADC, some people still have a great response to another ADC. So not having a good response to one ADC doesn't mean that you won't respond to another. There are 2 ongoing studies. One's a prospective study, TBCRC 064, that's looking at switch with Dato-DXd and T-DXd, and then TBCRC 067, which is a registry study, that's a prospective registry study. And then I'll just wrap up by reminding all of us that there is a lot of activity now in the curative intent space. So whenever we see activity in the metastatic space, we typically move those strategies into the curative intent space to see if we can prevent metastatic disease from occurring. So there are 3 studies looking at patients who've received neoadjuvant therapy, who have residual disease, and looking at folding in one of these TROP2-directed ADCs. As a reminder, about a third of patients who have residual disease will have a recurrence within 2 to 3 years and then die of related complications within 12 to 18 months. So there's a very high-risk population. Sarah Talani is leading the ASCENT-05 or Optimize RD study looking at escalation with sacituzumab govitecan and pembrolizumab. Then there's the TroFuse 12 study, which is looking at pembrolizumab with sac-TMT going against standard of care, and then TROPION-Breast03 looking at Dato-DXd plus or minus Durva versus standard of care. And then what if we move these strategies even earlier on in the course of disease? So I mentioned earlier the TROPION-Breast04 study, which is looking at neoadjuvant Dato-DXd plus Durva going head-to-head against against KEYNOTE-522. So can we replace conventional chemotherapy altogether with one of these strategies? And that study enrolled at 200% the expected pace, reflecting the enthusiasm of patients and providers to access these drugs early on. And then the TroFuse 032 study just recently opened looking at sac-TMT with pembrolizumab, followed by carbo-taxol pembrolizumab in the neoadjuvant setting. So going against the first, or the anthracycline component of KEYNOTE-522 here. Thank you.
So thanks, Heather. And, just sort of taking a macro, I was looking at all these studies and I was thinking, every time I see a trial that compares an ADC to chemo, I go, oh, probably the ADC is going to be better. And from a macro perspective, I think we've seen that the promise of ADCs in terms of delivery of chemo plays out a lot in oncology, not just in breast cancer. So we're getting a lot of questions of things we talked about before. I'm going to try to get to them in the end. But one I want to bring up right away, I think it's really interesting, Rita. We mentioned we were doing this webinar next week on HER2-positive GI cancers. And in biliary cancer, they have a bispecific anti-HER2 product, zanidatamab, that's approved, and actually people are using in biliary cancer. We're going to talk about it next week. Has that or any other bispecifics being looked at in breast cancer?
Yeah. So Zani just entered I-SPY 2. So it is part of the one of the arms that patients can get. It's kind of interesting. We're doing a lead-in of Zani alone. So patients who do well on Zani alone have the opportunity to just get Zani, which is really well tolerated, kind of like trastuzumab, pertuzumab. But if not, then you can layer in the taxane and the platinum as need be. So I just enrolled my first patient on that study.
Yeah, no, we've been hearing that Zani is very well tolerated. Yeah. So, Matt, there was a great symposium, I think it was last year's San Antonio, it seems a long time ago, on ADCs and mechanisms of resistance with sequencing. We talk about this all the time. I was really struck by the slide that Heather showed of Dato after other ADCs, including SASI, where they saw responses. Any thoughts about, we say, they have the same payload, they have the same target, but then you see different toxicity profiles, so they're not, it's not like they're two AIs that are exactly the same. How do you think through sequencing? Again, do you think more about the target being resistant? Do you like to sandwich chemo in between ADCs?
Yeah, it's a good question. I don't know that we really know the answer. I think this is, as we finally settle on which is the sort of the best ADC as we move forward, and I agree that in general ADCs look better than chemotherapy, but we still have to remember that we have these older chemotherapies, and so the question is, what's the best sequence? When do we use it? What's the mechanism of resistance to a standard TOP1 or TOP2 ADC? What is the role of a taxane post? So these are things that really need to be sorted out, I think, in the laboratory, and then we need to be bringing studies forward to really understand. I think as Heather said, it's clear that we're seeing some responses for one ADC after the other. That's true, but I think we'll need to design our studies to really address these questions.
All right. Well, let's get back to some of the questions again. Here's next Sunday. Will be ASCENT-03. It's going to be really fascinating, again, as Heather was commenting, to indirectly compare it to TROPION-Breast02 that's going to be presented as well. Very similar trials. So Hal, is SASE and Pembro, your colleague Dr. Talani presented that. She presented DB09. She had a pretty busy ASCO this year. How are you thinking through the use of this in first-line setting, and particularly the question we get all the time in people with prior Keynote 522?
Yeah, well, but I just want to build on the point you said, Neil, about these ADCs, and I think it's actually a sufficiently mature field that we should be looking more critically at the design of trials and the data interpretation. And here's where Florida cancer specialists could have a huge impact. You guys are the largest network in the fourth most populous state in the country. And if you all said things like, we have to see crossover if you're doing a first-line trial for a drug that already exists in the marketplace, that would have a real voice. Because what you're seeing now are things like, oh, this one showed survival and this one didn't. But that's because sometimes there's crossover in these global trials and sometimes there isn't. And for any of you who've seen what cancer care looks like outside of the United States and Western Europe, you know that the resources are vastly different in these other parts of the country where they're doing these studies. And I think you could really insist on that, and it would be very powerful. And the second thing you could do is to mount your own pragmatic trials. It's a very simple thing. Let's just randomize, SG versus trastuzumab deruxtecan versus Dato. Just do it. And instead of spending 10 years going to meetings like this and mawing over, indirect comparisons to trials, it would be a huge contribution. And there are networks, there's obviously Texas Oncology, there's other programs around the country that really have the capacity to do these studies. The cooperative groups will not, there's no funding for it and things, but it would be a huge contribution and an opportunity. Where do we stand? Again, I think you can over-intellectualize this. Multiple trials now have shown that in reasonably sensitive tumors, the ADC is more potent than dealer's choice chemotherapy. Now, the problem with the dealer's choice chemotherapy is there's a lot of variation in there. Sometimes they're getting vinorelbine or eribulin or capecitabine. Sometimes they're getting taxanes. But consistently, the antibody-drug conjugates are outperforming. And so, this is one of those things we learned in like high school algebra, right? If A is greater than B, then A plus C is going to be greater than B plus C, right? I mean, there's a rule, like Pythagoras knew this or something like that. And this is now true for adding Pembro. That's the C drug here in the equation. So if SASE is better than chemo, SASE plus Pembro is going to be better than chemo plus Pembro. That's it. And this is going to be true over and over again. So yes, first line triple negative, if they're PD-L1 positive and they haven't already seen Pembro, we give them SASE plus Pembro. It's not, that's a perfectly appropriate thing to do.
And if they've seen an IO?
Well, a lot of our patients have, because most high-risk triple-negative breast cancers in Boston are getting neoadjuvant therapy, and that includes Pembro, which is clearly a very active drug. And so if they recur, they've already seen Pembro, and as Heather just said, they tend to recur early, and you got to wonder what the activity of all these drugs is going to be after prior Pembro. But certainly in the ones who are naive to the IO, we would use a regimen like this.
So Heather, you talked about the fact that now we're going to see some data with Dato in the triple negative setting and sacituzumab at the same time. You can probably make some bets about what you're going to see, but if it looks indirectly like the efficacy is the same as it is, I think it looks that way in ER positive, I guess it's going to come down to tolerability. How are you going to think it through?
I think it will be exactly like the conversation that we just had in the hormone receptor positive space, in that it's going to be, if the efficacy is the same, which I doubt that the efficacy will be the same, but if the efficacy were the same, we'd be looking at the side effect profile, we'd be looking at the individual patient, any comorbid conditions that we need to consider. Do they have bone marrow involvement, in which case maybe SASE isn't the best choice. So I think there'll be really individualized decisions, and our conversations with patients are increasingly complicated as a result.
Do you think, Heather, there's going to be a day where we're going to look at TROP2 levels? We say everybody's got TROP2, it sort of doesn't matter. In lung, there's this assay looking at membrane cytoplasmic ratio that looks like it predicts benefit at Dato. Do you think we're ever going to get to a point where we're going to really look at the TROP2 level?
I doubt it. 80% of breast cancers express TROP2. We've seen activity in ASCENT. with sacituzumab in TROP2 low expressing patients. I think the story is probably comparable to what we've seen with trastuzumab deruxtecan, where you have the bystander effect, so it overcomes any potential heterogeneity. So I don't foresee that in our future.
So, Rita, we've been talking about tolerability issues with these ADCs, and interesting, I guess they really didn't report any particular concerns combining SASI with Pembro.
Yeah.
I mean, they both can cause diarrhea theoretically. Also, I'm curious in general how you manage patients on SASI. Do you use preemptive growth factors? Do you use preemptive antidiarrheals, as has been studied?
Yeah. No, I mean, I was pleasantly surprised that in the combination arms that we didn't really see an enhancement of diarrhea. But, the time frame of when you're going to develop diarrhea from sacituzumab govitecan is very different than diarrhea from immunotherapy. So, in general, I found SASI quite easy to manage. I do not generally use prophylactic growth factor up front. I use it if patients have issues. If patients are tolerating their therapy well, obviously antidiarrheal agents. If patients are struggling with diarrhea and cytopenias, then I will oftentimes consider a dose modification and growth factor in that case. But if patients are tolerating full dose well and it's just neutropenia, I'll generally incorporate the use of growth factor then.
So, Matt, let's talk a little bit about PARP inhibitors, and particularly in patients with BRCA mutations. How do you think about patients in a localized disease setting in terms of bringing in a PARP inhibitor as well as IO?
Yeah, so clearly with PARP inhibitors, as we know from the Olympia study, in the adjuvant setting, we have not only a disease-free survival, but a clear overall survival advantage. And so I view that the BRCA mutation is clearly a driver, and it needs to be targeted. And so that's certainly a priority. There are data, of course, a lot of data of combining PARP inhibitors plus immunotherapy. There was some rationale to do it. Hasn't turned out as well as we thought it would in the metastatic setting, but certainly we have safety data for the combination. And so if I had a patient that I saw was a candidate for both, I wouldn't hesitate to give both.
And exactly how would you do it?
Well, I think if a patient was, in the postoperative setting, receiving had the neoadjuvant setting had received pembrolizumab, and then the postoperative setting was getting pembrolizumab, I would simply add the PARP inhibitor along with that.
And what about tolerability issues with PARP inhibitors? We're going to talk about this in the next module as well with prostate cancer. Do you see issues with cytopenias or anemia? What do you see in terms of GI effects? And any updates in terms of data with AML, MDS, Matt?
I think that unlike, for example, the ovarian cancer world where patients are getting tons of prior platinum therapy, in general, the incidence that we're seeing of AML MDS is really low. In fact, if you look at the Olympia trial, the incidence was exceedingly small. So I just haven't seen it that far. Yes, have I seen a few patients? Yes, but in terms of being worried exceedingly about it, no, I'm not. In terms of the side effects, olaparib, I think it's a well-tolerated drug. Yes, anemia, some GI side effects, but for most of my patients, we can manage this pretty well.
So, Heather, you want to do a quick case?
I would love to.
So we're getting on the elevator going down, and I'm going, hey, what do you think about a 60-year-old woman who got the Keynote 522 for stage 3C triple-negative disease, gets a path CR, but 1 year later has a brain met, a symptomatic brain met. No other evidence of disease. She's HER2 low. What would you be thinking at that point? Would you, I guess the patient's already been treated locally, has no NED after removal of the brain met?
I might not treat her at all and just follow her very closely, frankly. We have such a limited number of active agents for triple-negative disease, and without any clear indication to treat her immediately, I would just favor close follow-up.
So a very practical question. I hear this a lot, actually going back to what we were talking about earlier, again, from someone in the audience. So Rita, I always like it when it starts out, 90-year-old female. We actually had a 103-year-old woman that we're going to present in San Antonio who wanted to be treated and is doing well. But anyhow, 90-year-old woman, stage 2, hormone receptor positive, HER2 1 plus, develops metastatic disease of the bone, adjuvant AI, gets fulvestrant ribo, and now has progression. NGS shows a PIK3 mutation. The person wants to start Capi, but the patient's on fulvestrant. Would you keep the fulvestrant going and add the Capi, Rita?
I mean, Capi, it can be very challenging to tolerate. I think it depends on, what her other comorbidities are, but I would imagine at that age she's probably got some insulin resistance.
But would you add the fulvestrant? That's the question, because they're on fulvestrant already. Would you Capi and fulvestrant?
Oh, progressing on fulvestrant?
Yeah.
How long on fulvestrant?
It doesn't say.
Yeah. I mean, I guess it's worth a try. If she doesn't tolerate it, then I'd probably move on to capecitabine or something.
When you see somebody take a deep breath and really think about it, you know that there's no good, real perfect answer to it. We see that a lot in oncology. So we're going to take a break now. Thanks so much to the faculty. Awesome job.